Hello friends, I am Dr. Raktiv and I am here to discuss on the topic of epidemiology of malaria. Let's begin. Malaria is a protozoal disease caused by the parasites from the genus Plasmodium. It is transmitted by the bite of female Anopheline mosquitoes. It has got three distinct stages: the cold stage, the hot stage, and the sweating stage. Fever occurs at definite intervals and at a periodicity depending upon the species of the parasite, like may occur every third day or the fourth day. How big is the problem in the world? Most of the malarial cases are seen in the African countries. However, the proportion of malarial cases have declined gradually over the years compared to the cases from the baseline of 2015. There was a minor surge of malarial cases in the year 2019-20 because of the COVID pandemic, as there was disruption of the medical services all throughout. However, the malarial cases have declined since then. Southeast Asian region accounts for 2% of the global malarial cases, and India contributes about 83% of the cases from the Southeast Asian region. About 95% of the malarial deaths occur in sub-Saharan Africa and the rest from the Southeast Asia. Almost all malarial deaths are caused by Plasmodium falciparum. The Plasmodium vivax is an important cause for the malarial morbidity outside the sub-Saharan region. Coming to the problem statement of malaria in India. It is a major public health problem in India, as we all know. And as discussed, there are about 95% of the India is endemic to malaria. 80% of these cases belong to tribal, hilly, and difficult to reach areas. But it was interesting to note that these 80% cases are coming from only 20% of the India's population living in these tribal, hilly, difficult to reach areas. Lastly, the major epidemic of malaria occurred in the year 2006 in northeast India. Since then, the overall endemicity of malaria has declined gradually. Coming to the characteristics of malarial transmission, it is predominantly unstable malaria transmission in India. The seasonal variability is seen and the intensity gets increased during rainy season. It is understood that during rainy season there are collection of water, the breeding sites of the mosquitoes increases, and hence the intensity gets increased, as well as there is seasonality in the trend of malaria. Most of the population has no or little immunity towards malaria. It affects all ages and sexes. However, few surveys in India shows malarial foci is in the forested area. It can be understood from the fact that the northeast India, which is full of forests compared to the rest of India, has got higher incidence of malaria in India. The transmission intensity is high and the disease burden is more in case of children. Coming to the vectors of malaria, here I have discussed six which are primary. The Anopheles culissifacis, which is also known as rural malaria. It is found mainly in the rural and peri-urban areas, and these are highly zoophilic in nature. Anopheles stephensi. It is also known as urban malaria, and it is responsible for malaria in urban and industrial areas. Anopheles fluviatilis is mainly found in the hilly areas forests and forest fringes. Anopheles minimus. These are found in the foothills of the northeastern states. Anopheles tyrus. It is an important forest vector in case of northeast India. Anopheles aproticus is restricted to the malaria caused in Andaman and Nicobar Islands. Apart from all this, there are many other vectors, but that are not primary, as for example, Anopheles sundaicus. These are found in the coastal regions of India. There are many others are present like Anopheles philippensis, Anopheles maculatus, etc. Coming to the major epidemiological types of malaria. Tribal malaria, it contributes to 50% of the falciparum cases in India. Rural malaria is mainly in the irrigated areas of the arid and semi-arid plains of India. Urban malaria, as discussed, is caused by Anopheles stephensi, and it is mainly in the peri-urban areas where there is poor sanitary conditions, there is low socioeconomic groups present, and uh, thus is a menace in the urban areas now. Malaria in project areas where there are construction sites going on or the development activities are going on, malaria is dreaded there. Uh, it is of particular concern because the people living in those areas belong to low socioeconomic, number one. Number two, the vector is very efficient in those project areas. There are collection of water here and there, breeding sites are in, and thus is a matter of concern to us. Border malaria, the high malarial transmission belts in the international and the state borders. On top of that, there is poor administrative control in the border areas, and thus it becomes very difficult to control malaria in these border areas. Similarly, the forest malaria is interesting to note that uh, that when a certain place was for forests have grown or there is settlements recently, but there was uh, no settlements or there was deforested areas beforehand. The new settlements have occurred. In them, what happened that the vectors they come from the forests, nearby forests. They go to the settlements, human settlements. They bite the humans. And after that, they come out from the shelters and rest outdoors in the forests. Thus, forest malarias are very controlled because the indoor residual spray and the other measures do not play a role in control of forest malarias. The vectors primarily rest outdoors and they bite the humans indoors in the shelters. So it is of much concern to us. Moving forward to the agent factors. Primarily, it is caused by four distinct species: the Plasmodium falciparum, Plasmodium vivax, Plasmodium pale, Plasmodium malariae. Very recently, in some parts of the world, the fifth species have also been identified. It is known as Plasmodium knowlesi. However, in the Indian perspective, these four species are of uh, more concern. As I already mentioned, that there are 50% cases or more in India, and these are caused by Plasmodium falciparum. 4 to 8% are the mixed infection. With mixed, I mean Plasmodium falciparum is mixed with Plasmodium vivax, while the rest is with Plasmodium vale. Please note, the Plasmodium malariae is confined to Tumkur and Hassan districts in Karnataka. It is not found anywhere else in India. Moving on to the reservoir of malaria. Chimpanzees in tropical Africa carry the infection of Plasmodium malaria. No other uh, reservoirs have been documented. Thirdly, the human reservoir is the only one who has the sexual parasite. Children can harbor the gametocytes more efficiently than adults. Why I have said so? It is because the children have got weak immune system and there is high parasite density. Thus, they can harbor the gametocytes more efficiently. In adults, due to their strong immune system, the gametocytes cannot be harbored easily. The malarial community is present until they are mature. The viable gametocytes are present in the circulating blood, infect the factor mosquito. Moving on to the relapses in malaria. It is seen in case of Plasmodium vivax and ovale. Relapses may occur 3 years after their first attack of malaria. So we have to be very cautious about it. Plasmodium malaria causes prolonged low-level asymptomatic parasitism. So occasionally the person who had asymptomatic parasitism may be a source of infection. That person may transmit infection sometimes. The infection may persist for 40 years or more. Thus, uh, the mosquitoes, when biting them, may get infected occasionally. Moving on to the host factors. As I said, it affects all age groups and the sexes, but it is interesting to note that the newborns are resistant to Plasmodium falciparum. It is because of the presence of fetal hemoglobin. Males are more at risk compared to females due to high outdoor activities of. On top of that, in India, females are more covered and hence the man-mosquito interaction is lesser compared to males. Sickle cell trait or the disease provides protection against the falciparum malaria. One thing to note is that the persons having Duffy negative blood group are protected against the Plasmodium vivax malaria. Let us continue our further discussion about those factors. The risk and severity is more during pregnancy. When a pregnant woman contracts malaria, the woman may have the intrauterine death, premature labor, or even abortion. As I mentioned, the malaria is more commonly seen in low socioeconomic status groups. It is more seen in the poor housing standards such as ill-ventilated or ill-lighted conditions. It is because when their room is ill-ventilated or ill-lighted, then there would be higher chance of man-mosquito interaction. The mosquito would be able to hide or camouflage itself, then leads to uh, mosquito bite in case of man. So leads to higher incidence of. It is also seen mostly in persons related to agricultural practices. Again, uh, it is because when a person is related to agricultural practices, there would be uh, higher chances of breeding of mosquito with collection of water. Hence, the man-mosquito infection is more. Similarly, the human habits of sleeping outdoors, nomads, or the persons who are not fully covered with clothing, so leads to higher chance of malaria getting transmitted. Coming on to the environmental factors. India's geographical location and climate is such that it favors the transmission of. Let me tell you that any kind of mosquito-related diseases in India, it grows well when the temperature is in the range of 16-30 degrees Celsius with a relative humidity of 60 to 80%. In this temperature and humidity, there is it is a favorable condition where mosquito breeding sites uh, takes place, and it leads to their increased uh, production. Thus, the man-mosquito interaction is such uh, conditions. On top of that, rainfall provides a good breeding site for mosquitoes. Interesting, the high altitude is a protective factor since at high altitudes the anopheline mosquitoes cannot survive. Lastly, a term known as man-made malaria. It is the consequence of the human undertakings. The burrow pits, the engineering projects like the hydroelectric dams, roads, irrigation channels, garden pools, these all lead to this breeding site of the mosquitoes. They get a good chance to breed, and hence there is higher incidence of transmission of malaria. To be effective, the density of the parasites must be adequate. The lifespan of the mosquito is important. After a blood moon, the mosquito must survive for at least 10 to 12 days to become effective in the transmission of it. If it dies before, then the malaria is not transmitted by that mosquito. So, the survival time after a blood meal is important. The indoor resting habits, diverse breeding habits, and the nighttime bite are important factors for the Anopheles mosquito. Here, interestingly, the forest malaria, the vectors rest outdoors in the forests. That is one exception. Rest for all other types of uh, malaria, the resting habits are indoor. Continuing our discussion, clinical features, there are three distinct stages. Number one, cold stage, hot stage, and sweating stage. In the cold stage, it starts with the lassitude, headache, fever with chills and rigor, vomiting, rapid but a weak pulse. It lasts for a duration of 15 minutes to 1 hour. Coming to the hot stage, patient here feels burning hot. There is intense headache, but there is no nausea. Gets reduced. There is rapid respiration in the patient. It lasts for a duration of 2 to 6 hours. And in the sweating stage, fever comes down and there is profuse sweating in the patient. Skin becomes cool and moist, the slower pulse rate. It is seen for 2 to 4 hours. The fever pattern, as I said in the first slide, that it repeats every third or fourth day depending upon the species with which the malaria has occurred. There is a tendency of relapse and there is hepatosplenomegaly. Plasmodium falciparum malaria is a severe form, as discussed, with fever being irregular or continuous in time, a very high mortality rate. So, in this case, the stages are overlapping. You will not see the cold stage, hot stage, or the sweating stage in a distinct manner. These stages overlap in case of Plasmodium falciparum. There you may see delirium, hemolytic jaundice, and anemia in falciparum malaria cases. Coming to the complications of malaria, firstly, the cerebral malaria, the acute renal failure, liver damage, gastrointestinal symptoms, dehydration, hemolytic anemia, black water fever, hepatosplenomegaly. All these complications till hepatosplenomegaly starting from cerebral malaria are more seen in case of Plasmodium falciparum malaria. The herpes and the renal complications are most commonly seen in case of Plasmodium vivax malaria. Thus, we say falciparum malaria is the dreaded one. Thus, since it affects the uh, brain, there is high chances of mortality in patients. Coming to the diagnosis, malaria is diagnosed clinically. It is suspected with the following clinical features as discussed in the previous slide. For the laboratory confirmation, microscopic there we take the blood smear. There are two types of films we make, the thin film and the thick film. The thin film is valuable to identify the species of parasites involved in the causation of malaria, while the thick film is reliable for the searching of the parasite in the bloodstream. What are the advantages of microscope? The sensitivity is very high. With this, I mean the true positives. If you suspect, if you do a microscopy in a suspected malaria patient, then the chance of finding malaria in that suspect is very high. That is known as sensitivity is very high. Number two, since it identifies the species of the parasite and it also searches for the parasite in the smear, so we can quantify the parasite in the patient, and identifying the species means it is possible to detect the different species of malaria parasite in the patient. Accordingly, the treatment can be. Second is the serology. It is not much of clinical importance, and it is, however, of epidemiological importance because it becomes positive after 2 weeks or more in case of primary infection. Positive test in serology doesn't mean that the patient is having current infection. It only determines whether the patient has had malaria in the past or in the recent past. That's it. Thus, serology is mainly for the epidemiological studies rather than for the clinical management. Moving on to the approaches to malaria control. Number one, the surveillance and case management. The case detection. You can do case detection actively or in the passive manner. Passive manner means when a patient comes to you or to a doctor or to a healthcare facility and gives the mentioned sign and symptoms, then the healthcare facility suspects of malaria and with further management, the case detection occurs. That is the passive case detection. For the active case detection, the healthcare facility goes to the house to house and checks for the malarial parasite. So in rural areas, it is commonly done by the multipurpose work uh, from the PCs. They go house to house and visit them, and all the fever cases they do a smear. This microscope. Thus, it is known as active case detection. Secondly, the early diagnosis and complete treatment is also important. It helps in early detection, early treatment, and thus complete treatment ensures that the resistance to malaria parasite does not occur. Thirdly, the sentinel surveillance. Now, coming to the integrated factor management, the indoor residual spray is important. control. Apart from the forest malaria, all other mosquitoes of malaria rest indoor. Thus, when we do indoor residual spray with organophosphorus compounds in the walls, flooring, then when the mosquito would rest in that walls or the flooring, then it serves as a contact poison and the mosquito dies. It leads to the efficient vector management. Secondly, the insecticide treated and long lasting insecticide treated bed nets are there where the mosquito nets are treated with the insecticides such as malathion or phenylethion, and in that case when the mosquito sits on those mosquito nets due to the contact poison, the mosquito dies. These mosquito nets are effective till 20 washes of those nets, and in terms of months it is effective for 3 to 6 months. Thirdly, under integrated vector management, the anti-larval measures like the source reduction is also very important. When we destruct the breeding sites of the mosquitoes, then there would be lesser population of the mosquito and hence the malaria would control effectively. These are the approaches to malaria control. Continuing that, the epidemic preparedness and early response. Just before the monsoon starts, uh, creating awareness among the community and giving the suggestions of do's and don'ts, what to be done and not, uh, is the epidemic preparedness the community by the health workers. And early response means when there is community participation, when the community is aware, they will approach the healthcare facility in the early stage, and hence there would be better malaria control. Supportive interventions like capacity staff with the regular trainings and refresher trainings, the behavioral change communication when their awareness generation uh, is such that there is change in the behavior of the community and ultimately it leads to source reduction. Thirdly, there is this intersectoral collaboration. There must be collaboration with the health department, the vector control management department. This will lead to uh, this will lead to better malaria control in a community. Monitoring and evaluation is a part and parcel of malaria control, and research activities of that newer methods of malaria control can be taken care of. Coming on to the treatment. Firstly, the Plasmodium vivax cases are treated by chloroquine. Chloroquine is given at 25 milligram per kg body and it is divided 3 days. It is given as 10 milligram per kg on day 1, 10 milligram per kg day 2 and 5 milligram per kg on day 3. With that, we add Primaquine, which is given at 0.25 milligram daily for a period of 14 days. Coming on to the treatment of Plasmodium falciparum cases. There are two divisions, one for the rest of India, the other northeastern India. Coming to the rest of India first, it is artemisinin combination therapy, ACT, where we give artesunate at 4 milligram per kg body weight for a period of 3 days, plus sulfadoxine at 25 milligram per kg and pyrimethamine at 1.5 kg. The sulfadoxine and pyrimethamine are given as a combination. All three medicines are given on day 1. It is followed by the single dose of Primac at uh, 0.75 per kg daily. In case of Eastern India, we the artemisinin combination therapy comprises of artemis, that is 20 mg, and lumefantrine, is 120. As per the age-specific dose, we give it for 3 days. And it is followed by a single dose of primaquine at 0.75 mg per kg day 2. Thus, for both rest of India and northeastern India, we give the medicines, the artemisinin combination therapy for a period of 3 days, and on the second day, we give an additional primaquine. That's it. And if we are suspecting a mixed infection where the Plasmodium vivax and falciparum are there, then it is same like uh, Plasmodium falciparum, like artesunate and sulfadoxine pyrimethamine combination for rest of India. But the primaquine dose is 0.75 mg per kg for a period of 14 days, starting from day 1. Similarly, in Northeast India, the artemether 20 mg plus lumefantrine 120 mg is given 3 days. But again, here also the primaquine dose is started at 0.7 mg for a period of 14 days. Coming to the chemoprophylaxis, it is recommended for travelers from the non-endemic areas who are going to a malaria endemic countries or places, or for a short-term measure like soldiers or police when they are posted in some uh, endemic areas, we recommend the use of chemoprophylaxis. What is to be given? It is doxycycline is to be started before arrival. Weekly chloroquine is to be started 1 week before arrival. These prophylactic measures should be continued all throughout the duration of their stay, and it is also to be continued 4 weeks after the last possible exposure. That means after they return from endemic areas to their town or a non-endemic, they should continue these prophylactic measures of medicines for another 1 month. Coming to the control measures of malaria, firstly the anti-adult measures. We give residual spray by Malathion penithrothium. It helps us to kill the adult mosquito. These are contact poisons. The indoor residual spray reduces the longevity of the vector. Thirdly, the space application in the fog or mist helps us to control the malaria vectors who are outside the house. Mostly it targets the forest malaria. Individual protection like the repellents, the protective clothing, bed nets, mosquito coils, screening of the houses with meshes and all. These are all other individual protective control measures for malaria. In the anti-larval measures, we can use larvicides like Tamifos, which is widely being used. Source reduction, where uh, we tend to reduce the mosquito breeding sites, changing the salt content of the soil. Here, one more thing we can take up is the biological control, where use of larvivorous fishes like guppy or gambusia helps us in the uh, to eat the larvae, and hence there is reduction in vector density. Thus, integrated control, where the use of residual insecticides, the bioenvironmental measures, and protective measures at the personal level combined will help in better malaria control in the community and decrease in the malaria cases. Thank you very much. That was all in today's lecture. I have completed most of the things of malaria and its epidemic. Thank you.